So we're really pleased to have you, Michael, and thank you,
Thank you.
for coming.
Thank you. Good morning.
Yes.
Good morning.
I want to thank Carl Saturn and Dr. Grimes for inviting me to speak about the military culture. I think that's an issue that you all read about in the newspaper over and over again about the need for therapists and services for our military servicemen and women. I think in the next several years, this is going to become a really major issue for all of us because there are very few, relatively speaking, in terms of how many military people we have and their families, very few trained therapists who can really work with this population. One of the major obstacle and challenge that we have as therapists, as civilian therapists, is most of us have not been in the military. And so we lack the actual experience of what it really is like. So the best we can do is really train ourselves. And also in the next generation of therapists is to train a lot of military people who are coming out of the military to get into the field of psychology and social work. And because they have the experience and we want them to be able to get the education and knowledge that they're gonna need to work with those service people and their families who are coming out. And we normally talk about post-traumatic stress disorders, but that's the big heading, right? I mean, it's like, you know, how can you be in a war or away from home for as many times as you are and not come back a different person, right? And in many ways, in a very negative way with all the stresses that they have to deal with. So what I like to do, what I've done is, it was a challenge for me as a clinician to really put together in an hour and a half a presentation on the culture. It was more a question of process of elimination. What didn't I want to include? So the first time in 30 years of doing lectures and seminars, I'm using a PowerPoint. Never used one, never made one up. I actually said and created one, very easy, which is kind of nice. So bear with me a little bit because normally I tend to speak and kind of let everything flow. And so please feel free to participate, ask questions, feel free to contribute. You may know things that we need to know that I may not cover here. So at any given time, feel free, those of you out in cyberspace, you can write to us as well as you here can actually ask the questions. What I like to do is basically cover, in terms of the cultures, like what is the military culture? Why do we need to know about the military culture? I'm going to show you a bunch of statistics just so you get an idea of how serious this issue is. And we tend to forget. We go to bed under a nice roof and warm house, and we forget that we've got, at one point we had well over 100,000 troops overseas, and some of them go back second, third time as well, which creates additional stress. So as clinicians, we want to be sensitive to many of those issues and learn what they must be going through so that we can integrate the skills that we learn as clinicians. The whatever skills we have in terms of relationships, communications, dynamics that go on, that we learn in terms of how to treat with civilians, how do we integrate it with the mentality of people in the military and their families? We'll talk a little bit about how do we define service members in the military, their ranks. I'm going to spend probably a major portion of my talk on how to integrate working with the families of the military personnel. A lot of times I tend to use the word soldiers, but I know that Marines tend to be kind of, they object to be called soldiers. People in the Air Force are called, airmen and all that. So sort of the generic word for military personnel, sometimes us civilians, just use soldiers. So I don't mean any disrespect if I use that. And then kind of want to tell you that the importance of access. Most of the military people live on bases. Most of those bases are in remote areas. They're not in the middle of Los Angeles. They're not in my neighborhood in Encino. They would be someplace in the desert or someplace in remote areas. So quite often, not only don't we have enough therapists available, especially in that area, they don't have access. And that's kind of what got me into dealing with the military. Not so much from a clinical perspective, but I was working on a project several years ago to find a way to provide therapy for people who are homebound from injuries and people who live in remote areas using video, because with that new technology, Skype and all that, this was becoming available. But to me, Skype wasn't really good enough, so we're waiting for technology to improve, which we have. We'll talk the last 5-10 minutes about the technology and how you can provide comparable services to anybody who is in remote area, anybody who has access to internet, and just with a little video camera, $30 webcam, can actually see you, you can see them, and you can provide services. With the military, the advantage is that a lot of times the person in the military may not be physically in the same location as their spouse or their children or their parents. And with video, what we can do is we can actually capture, the therapist can actually work with the Marine and on the base, and the spouse who lives in a different state, so we can actually see 2, 3, 4 different people in different areas all at the same time. So we're able to provide additional services to them because, again, part of the military issue is that when you're in the military, there's a lot of isolation. You're away from your family. You're away from your home base. You're away from what feels comfortable. So to be able to connect with people in your family elsewhere, that adds that kind of support. So one of the things that you find a lot, what I found a lot is, newspaper clips, right? I mean, I started cutting news clips to struggle with war trauma, right? Deployments raise risk of abuse, neglect. Now, you read these this is just a few headings I wanted to put together. Long tours. We know that stress is related to how long a person is in Afghanistan or in Iraq, and also how many times they went back. Those things really have to take into consideration because post-traumatic stress disorder continues to build up, not only for the military person, but for the family, because they're getting farther and farther away. Camp Pendleton, which is not far from us in San Diego, which is really how I got involved in it, because one of the commanders heard about my work of providing access to people in remote areas. Says, well, our people in remote areas, we need that kind of help. The problem with the military is that it's a government agency, and the red tape just to get through, to get something new done, is really, really difficult. So we as clinicians have to also educate the politicians and the people in the military to be able to show them. And we're working with the school now to put together some pilot programs to show, with specifically working with comparing the quality of service we give to military people via video, that it's very comparable. We know from other experiences that it's about 94% comparable. And it's only 100% when you compare it to nothing, right? So we need to be able to do that. So a couple other clips. Again, newspaper articles, one after another keep telling us that we just don't have enough therapists. Suicide rates, we're going to talk a little bit about suicide rates. This is increasing dramatically. Yes. And I believe I have a couple of slides specifically talking about those numbers. And those are all slides, so we need to sort of like almost double. I mean, slide meaning 2007, 2008, and there's so much more was going on in not only that we've been in Iraq, but we entered into Afghanistan in big way, and we just added, I think, 30,000 troops not too long ago, and supposedly we're supposed to be out next year. But yeah, the suicide rates are going to continue to go up. So yeah, I have a couple of slides on that. Thank you for that comment. Divorce. One of the major, in my opinion, it's one of the fastest growing, the vet family, the military family, it's probably one of the fastest growing at-risk population, because we have so many of them right now. And divorce and domestic violence is huge. It's huge in the civilian population, right? What, 60%? I don't know, whatever it is at this point, 50, 60%. In the military, I've heard figures that go up to 80%. And again, those veterans who are looking for help, they go to the Department of Defense programs, they go to the VA. The VA is the major provider. And it's broken. They have to wait for months and months and months. That's part of the suicide issue, is that, when you are in a position, in a place where you're ready to kill yourself, you just don't know where to go. And you say, well, come back in 6 months. We'll see what we can do for you, and come back. You can imagine where it puts the person. Okay, so let's go to some statistics that I think are important. Okay, 2001, we've had 1.64 million deployments since 2001. And I think that's like a year old, so you can add another 30,000, 40,000. 2 million children. So one of the things that is being one of the subpopulation of the military is 2 million children are affected by military deployments. 700,000 currently. Okay. The big number today we're talking about is 1 in 5 soldiers, Marines, service members is affected by post-traumatic stress disorder. I think it's higher than that. Okay, that's the ones that we know about. And we'll talk a little bit more about again, it's part of the Marine culture in terms of ego, in terms of I'm strong, I'm taught to fight, right? I'm a warrior. And 90% of the servicemen at war are men. I think 90%, I think 10% are women. So, they're already entering, young guys, 18, 19, 20 years old, right? We all remember when we were young, we just kind of thought, nothing is going to get in our way. Then we go through all this trauma. We come back, and we don't want to tell anybody because we're afraid that they're going to laugh at us, or we're too weak, or there's also other implications we're going to talk about. But 1 in 5, that's 20%, probably is higher than that. Women in the military suffer from post-traumatic stress disorder, and they tend to suffer even more deeply. Okay, I assume part of it that there are more emotional implications, as also in terms of leaving the children behind. They tend to be more stressed out more when they're away from their kids. So when you work with people in the military, you want to consider all those things, because you need to be aware what are some of the issues that they may not even know, they may not recognize themselves. There are several programs. I mean, the VA is putting out a lot of programs. They're recognizing the need. And there's more and more money being put into programs. It's all about money. How much money do we have to create programs? So one nice thing about internet is that you can go and Google much of this information, and you can Google to find out the services. We'll talk toward the end about TRICARE. TRICARE is the official or the military insurance, health insurance for everybody in the military all over the United States. So just like you have Blue Cross and HealthNet, TRICARE is automatically, when you enter into the military, you are covered by TRICARE. One of the great things, so I'm going to not wait for the end, because I'm talking about it now. And so one of the great things about TRICARE is that they're the only insurance company right now that are willing to cover therapy using video systems. So the only problem with TRICARE right now, and that's going to change, is that they'll cover the military personnel, including their families, as long as it's from the therapist's office to another office, meaning an office on the base. Most bases, all bases have clinics, hospitals. So as long as it's an established office where the military personnel can go make an appointment, sit in a nice room with a camera, and they can talk and see the therapist. Now, at least we have that. I'm looking and I'm advocating and I'm working really hard with the military to allow people to use it out of their home. Because part of the thing we're going to talk about is a lot of them want anonymity. They don't want to walk into a hospital or clinic. Everybody says, hey, what are you doing here? Well, I got to see my shrink, That's kind of scary. So a lot of them, wouldn't it be wonderful to be able to give them the privacy and the anonymity where they can do the same thing out of their home? Now, it's moving in that direction. I think within 6 months, we're going to get there. They'll cover it. I'm working with Blue Cross of California, and they're saying within 6 months to a year, they'll be willing to cover everybody who has Blue Cross using video therapy. It's really the wave of the future. This is really, those of you who are students right now and studying it, you want to learn more about the use of video because you'll be able to to get a lot of clients and help a lot of people who otherwise cannot make it, and they'll be covered by insurance. So they do have fairly good coverage for therapists who are. You have to be on their panel, in other words, and they do accept right now licensed therapists. You have to be. They won't pay for interns, but they will pay for licensed therapists, and they do cover pretty much at the same rate as Blue Cross, a little bit higher than that. The good thing about TRICARE, quite often, they don't have copay, which is kind of nice, at least for 12 sessions. So a lot of the service people can actually come in for free. 28% of the Hispanic population, they're the highest percentage of post-traumatic stress disorder. Blacks 19%, whites 14%. And again, all these numbers, I think you can increase them by a few. One way to recognize issues at home when the service person himself or herself aren't disclosing anything, they're not talking about it, is you see it in the children. So you may have a mother or a father bring kids in to you because they're all kind of issues. They get headaches, they can't sleep at night, they have high blood pressure. Remember, they live in an environment, and you have to know that if there is a service person who just came back, or even a few years later, so you want that's one way to recognize that something is going on with the military person when they themselves don't come or they don't even recognize it. They're just saying they're fine, and it's very common. They walk around thinking everything is okay, but the kids are the one who are going to carry the burden. So. We want to look at that. Okay, suicide statistics, as we brought up before. What we see is that it's continuing to rise. It's probably going to double this year. What we know is that many service people who committed suicide have seen a therapist within 30 days or 60, 90 days before they committed suicide. I think it's the next slide will show it. I think something like 30% or 40% have seen somebody. So you kind of have to wonder what is really going on. Is it that people are not trained to catch that? Is it maybe just too late? Is it they're not going often enough? You're raising a great question that we are struggling with now. That is, when you're licensed in California, you can only work with residents of California, right? So unless you work for the federal government, if you're working for the VA, you can see anybody from any state. They have their own rules. But when you're licensed in a state, so if you're licensed in California, my understanding is that for sure if somebody lives in California, then you can see them. So they could be, with video therapy, it could be anywhere within the borders of California. Now, my guess is, and I need to check, I'm not sure about that, is since it's a resident of California, if this person is on a base in another state, like let's say in Arizona, can you still legally and ethically work with that client? Now, this is also changing. This is another thing that, because of the changes in technology and internet, is at some point we're going to have probably one license that we apply for, and you have I think there's already a national counseling license for counselors, but I'm not quite sure that covers everybody. But eventually we'll have probably one test, and if you like, whatever state you license, you'll be able to see people from all over the country. Well, I don't think there are really any rules on that because it's so new, but we have people work with people in Afghanistan and people work with people in Iraq. There are also bases in Germany and many other countries. So out of the state seems to be okay. It's within the state that you have to stay within your city boundary. I'm sorry, within your state boundary. So, okay, are we good?
Yeah, go ahead.
36% were seeing a therapist, right, within 30 days of suicide. Stigma, right? We started talking a little bit about it, is a major, major issue. Not only in terms of the personal sense of, I'm tough, I don't need a therapist. Therapists aren't going to help me, But it's a stigma in the military that if you are seeing a therapist, or even if you're diagnosed, that something is wrong with you and something you're weak, and then there's the issue of going back to the hierarchy through the military is that you may not get re-enlisted. You may not, there may be a black mark against you, and that has been like that before. This is changing. I think the mentality of the military is recognizing now, and they're talking more and more. You hear more and more generals and commanders talking about actually encouraging people to go and seek help, that it is really important to do so. A little bit about how it's, the families. What's important to look here is that in terms of the age of the spouses, is about half of them are below the age of 30. Okay, we're talking about young people, right? My time, teenage year was through 18, 19. Today, teenage year is through 25. So you've got 30% that are 25 and less. In terms of the age of children, again, it's crucial to see that about probably 3/4 of the kids are under the age of 11. So you do have issues of, when you're moving from one place to another, you have issues of what do you do with the kids when somebody goes into the military or going on deployment. You gotta have to consider that. Changing schools. A lot of us hear about military brats, right? It's like, quite often they have no real stability in one place. A little bit in general in terms of military culture, remember that the military culture can span for people anywhere from somebody who's been in the military for a couple of years to families over generations of families that are military families, right? So as you're taking history of these clients, you need to kind of know, is this the first generation of a client in the military, or is this somebody who's been basically known? My father was in the military, my grandfather was in the military, and it's part of that's what you do. Basically 90% of men being deployed, 10% of women. Half of them are married, and more than half have children. Single, 47%, about another half. So, okay. So, military sexual trauma is a big issue too. And let's look at some of the concerns. Okay, 52% of women and 29% have experienced offensive sexual. That's huge. Okay, and again, a lot of times they can't talk about it because who are they going to report to? So it creates an additional layer of stress. Unwanted sexual attention, 31% women, 7% men. Sexual coercion. So you can see between, if you just look at the percentage, it's big. So you got 48,000 of women experiencing that. Let's see. Okay, comparing it to sexual assault in civilian life, more distress and mental illness, because they're already, in addition to the sexual advances or sexual connotation or sexual, harassment, you also have the combat issues, being away from home and supports. Lower physical health and self-esteem, so we have to address those things in them. More PTSD these symptoms, more severe consequences. Again, that's the issues that I just said, that you may not be able to report to someone. You're afraid that nobody's going to believe you. A lot of times they make you, the feeling that a woman would get, and men too, is is either disbelief or dismissal of what's going on, because part of it is they're busy doing a war. It's like, that's not important. The war is important, but the casualties are going to be there. And that's, on top of it, is that combat exposure.
Dr. Harani,
Yes.
another question regarding personality types and exposure. One of the questions is, is there any evidence that locus of control types relate to greater tendency for PTSD? And that question is asked by James Craig.
Yeah. I'm not sure I can answer that. I really haven't looked in those studies, so I'm sorry. Don't really have good enough answer. So, okay. Mental health task force findings. Divorce and family violence are the major issues you're going to see in families. So let's talk, that's going to get us a little bit into family and couples. Families are crucial for recovery. That's really, really important for you. Even if you get the service person coming in, to work with that person in isolation, just with that person, is going to be very, very difficult because that person have lost a great deal of support system. They were relying on what's going on for a couple of years or a few months someplace else. So you have to bring the family in. But you run into some challenges. Some of the challenges are confidentiality. How do you maintain confidentiality when you're working with the entire family? And you're also dealing with challenges with couples that teaching the family to be supportive, and quite often when you have somebody who's angry at you and somebody who's beating you up, the last thing you want to do is be supportive. So we need to teach the family members how to communicate in a way that it becomes more empathetic, becomes more supportive. Just basic definition of post-traumatic stress disorders. Okay. Common stressors that we need to think about. Life threat. When you are at war, you are constantly thinking about, am I going to be next? Okay, so you can imagine you're spending several months out, day in and day out, in the middle of the night, just feeling the anxiety of, is the next time you're going out, are you going to get killed or are you going to get hurt? Loss of friends, people that you spend close time with, and you have to deal with. You don't have time to grieve. You don't have the time to just process what's going on until you come back home. Inner conflicts, wear and tear, lack of control. Okay. We know by now that behavioral cognitive therapy is probably the most common that's being used with post-traumatic stress disorder. Okay, and I won't go into, you all learn that in school and you can get plenty of, you just kind of need to know that that's one of the main model that we use. Exposure therapy, a lot of people don't know what exposure therapy, which is kind of something I've done a lot before. It's basically desensitizing the person. And one just general way to do this is to help the client sort of relieve the events and the experience, but at the same time teaching him to relax, teaching him to have more control. And that's a process, and you need to really prepare the person to learn about different ways to relax and to kind of balance themselves in terms of their past experiences with the ability to have control at the moment too. So let's see. EMDR, again, it's just another technique that seems to be working. I've never used that myself, but I know people who have used it with great success. And stress inoculation therapy, a lot of us don't hear about that. And basically, probably the best way to define it would be, let me see, I have a... It's basically when you teach people ahead of time, you train them to be prepared. You condition their mind to be prepared for a possible trauma. And that'd be something that the military is doing a lot right now. They're actually preparing the people before they go out on the field. And it's just kind of mental conditioning. You just get yourself conditioned. It's like, you rehearse and you rehearse and you learn how to be prepared so that when the event occurs, you're more prepared. It doesn't take you by surprise. Yes?
Hi, my name is Christy Rose, and I actually am married to a recently retired Marine Lieutenant Colonel. And the big elephant in the room has always been the stigma. And one of the things that he found with his men, and I think that is becoming more popular with the military, is experiential therapy. It's not frowned down upon so much. They don't have their guys rousing them. In particular, I run an equine therapy program, and we
Right.
found when we get the guys out there, they're, especially the guys who grew up with horses, grew up on farms,
Right.
they're able to just tell their buddies, yeah, I just went out and hung out at the ranch.
Right.
And the stigma's not there so much, and you call it learning. So I would encourage any therapist to look at kind of experiential things, because that's, especially since military's mostly men, it's more of a guy thing.
Right.
It's getting them out doing things, and it's not frowned
Right.
upon so much.
Yeah, thank you for mentioning. Equine therapy is something that a lot of people are just not familiar with. And the idea behind it is that you're using horses to connect back with your own feelings, because a horse mirrors you by nature, mirrors you. Like so, if you're anxious, you find out that the horse gets anxious, and by working with big animal like that, it helps you with your experiences, and they use it with autistic children and many other areas. But you're right, that's an excellent experiential approach to desensitization too. Yeah, thanks.
Eric Knapp has a question actually about the DSM description that you talked about. He wants to know that if you think that the current DSM-4 section of the PTSD currently reflects what you see in a PTSD vet.
Well, I know they're revising the next PTSD, so I'm not big on labeling. I'm not big at the definition myself, so I'm probably not. I as a clinician never use labels except for when I need to in terms of communication and just kind of be able to relate something that may convey what we're talking about. So these are just definitions. You can't rely on definitions when you're working with clients. You have to really get to know the clients. You really have to know the definition, put them in sort of back burner, so to speak, and basically, I look at the person as a whole and not as a label. So I'm not big on the DSM definition. Yeah. Yes.
I want to add to that. This is Dr. Allen again. Dr. Roney, there's two reasons for that diagnosis. One, so that you and I can converse about
Right.
the patient. And secondly, in the past, we have to have a diagnosis for the insurance company.
That's
And
correct.
that becomes a legal problem.
Right.
And they're going to go by the exact definition as to whether or not
Right.
there's coverage.
Right.
And so possibly we need to add to whoever called in or wrote in about that definition to deal with that issue of changing the definition slightly in a way that would cover payment unless all of the therapy would be billed to, what's it called, the
TRICARE.
The TRICARE. Yeah.
TRICARE.
Right.
If it's billed to Blue Cross, whatever, perhaps they're going to be using a different definition. Would you address that?
No, I think that all the insurance companies use the same definition, the same procedure codes. So you have to, for insurance purposes, you have to follow the definition, in order to cover it.
Will you be covering also the, not where a person actually kills another person and dealing with the guilt of that, but also the guilt of your buddy being killed, whether male or female, and you didn't get killed? And one that I ran into of a personal patient that I saw, where he climbed a tree to escape, and he felt a bullet pass between his cranium and his ear.
Mm-hmm.
and at the moment, he didn't realize what had happened. Then it struck him that that bullet almost went through my head.
Right.
And he just came apart at the seams.
Right.
Soiling his clothes and feeling ashamed of that. So there was no event that really did occur, no injury.
Right.
But just the perception that, yeah,
Well, as you know, fear, if you get caught up in that fear in the moment, it feels so real to you that you get stuck with that.
would that last event come under our definition of PTSD?
Well, I think the definition is not so much based on the event. It's really more based on the emotional implication involved with that client, their behavior, their the way they deal with what's going on in their life at the moment. So I'm not really going. I mean, those are really great questions, and I think, as I said, we can spend hours and hours going into specific, and definitely there's lots of issues with shame, guilt, feeling with why me, and why I'm okay, and then my half of my platoon is dead. Those are really major things we need to deal with, and that's again going back to as a civilian, someone who has not been in the United States military. I wouldn't want to take on some of that myself, so I would want to refer those kind of clients to somebody who's actually been in the military. So there's certainly a large range of people that might want to contact me or might want to come see me, or anybody on my network. But just like working with any other culture, if I'm not familiar with the Asian culture, and I have an issue that I cannot handle, not because of the psychological aspect of it, but because of the culture, I need to refer them someplace else. And that's true for us too. We need to understand that we have limitation in terms of understanding that culture. And I have referred people out to someone else when I felt that I wasn't there. I just, there's certain things like, being shot at may be very foreign to me. So the next best thing is actually to refer them out. Yes.
I guess one of the reasons that Eric Nath, who asked the original question, is that he personally finds the VA's insistence on particular stressful events rather than recognizing that the war environment is in itself stressful. So, for example, a service person who may not have a combat job, still ending up traumatized. And so again, that's the definition, going back to the DSM-4 of the definition of PTSD. So you gave another example, Dr. Allen, where it was survivor's guilt, that sort of thing.
Right. Yeah. Thank you. Yeah. When you approach the people in terms of asking them when they come to you for the first time, is the question: do you ask them directly? Were you exposed to trauma? Or do you do it indirectly? I found that directly asking a direct question is usually is not particularly helpful. It's like asking somebody, why did you do something? Okay, so you really want, this is just kind of examples that, ways to approach a sort of indirect way to get the person to start telling you a story. Because ultimately, what you're really looking for is the story. You're not looking for this specific, well, this is what happened, and, now what? Where do you go with that? So, other concern we have is you need to know what medications they're on, because many times, if they've already been diagnosed, or even if they're not diagnosed, they're going to have their own medication, right? So they find their own way to medicate themselves. We'll talk a little bit, if we have time, about that. But you want to know medication, and quite often, we don't know a lot about medications. So you need to find out what those medications do. Very often, they'll be able to tell you. Confidentiality is always an issue, because there's always confidentiality, and anonymity is that quite often they tell us, I don't want anybody to know that I'm coming here. Please, including their families. Quite often I have people who say, well, I want, nobody knows I'm here. Record keeping, if they're still in the military, you have to ask yourself how much information you want to write down. How much do you want to protect them? Okay, so it could come up where you may have to disclose certain things, so you want to make sure that you are recording the right information, but also protecting your client. Because some of the stories they'll tell you are awful. I mean, there's some really things that they'll tell you stories, and they'll tell you, I don't want anybody to know. I feel so much shame over it. I feel so much whatever. And just the idea that you're writing it down creates additional anxiety. Generally speaking, I don't take notes except for 1 or 2 words here and there to remind me. After the session, I write notes. Because the minute you start writing notes when somebody telling you things that they feel ashamed of or they feel anxious about, they'll stop. You know, because they don't know where it's going to go. Therapist gender is another thing in terms of our culture is, you know, you need to know whether this person is comfortable working with you if you're a woman or a man. You have to be sensitive to that. Sometimes they don't know. They think, okay, you're a therapist. But you might find that your relationship in terms of gender is not inducive to opening up. And again, you have to recognize that. So, military, common stressors on the military. Did you have a question? No? Okay. Okay, so we have deployments. Every time you get deployed again, you're going through the whole thing all over again. So that you have to kind of know how many times this person's been deployed. Relocation, even people who are not going to the war, very often they get relocated from one place to another, and very often it's hurry up and wait. And that builds up stress on the family because sometimes they'll move with the entire family and they don't know when they're going to go. Again, the idea of separation from family member, just like reintegration with family, there's always an adjustment. You know, we forget sometimes. You know, you think, oh great, he's back. Everything is great now. Everybody's just really cool with that. We're all happy, and you do have that happy moment. And quite often, if there's post-traumatic stress disorder with a person, or any kind of stress, it doesn't take very long when that begins to show itself in the family. A lot of times they come back out of the military, they gotta look for a job. Okay? Go look for a job today is an economy when you're not in the military, so it's additional stress for that. Dealing with children and parents and the parenting issues is always an adjustment. Again, the financial with jobs. Infidelity and trust is another major issue. You've been away from the person for a while. You come back. Sometimes very often there is disconnection, you know, and you're going to try and find someplace else to feel good, you know, or you've been away for so long, especially for men, been away is coming home. It's like, okay, what were you doing for 8 months when I was away? And so there's a lot of mistrust there. And, you know, a lot of time without particular any reason. It's just that I was away for 8 months. You must have done a lot of things that I should know about, you know, that kind of stuff. So those things have to be discussed. They have to come out. Roles and responsibilities also switch. When you get deployed, and your role in the family was the head of the family, now the spouse is the head of the family. Now you come back and says, hey, I'm back, so I get the head of the family role. And the other person says, well, wait a second, no, I like being that, you know, or who are you to tell me that? It's like I did a good job, I can do it. So there are sometimes, you know, with teenagers, somebody comes back after 8 months, a year, and by that time, in 10 years, 1 year is a long time, and that teenager turned from being dependent and listening and doing everything that dad says to, who are you? I'm the man in the house, right? It's like now there's that kind of competition. You were away, you weren't here. I did everything we needed to do. Yes.
Eric Nat has a question actually kind of about that. Has the military recognized that PTSD symptoms may have a delay between when they're coming home and when you're seeing symptoms? Yeah.
It's very well accepted and known that it could show up years later. Everybody can be just fine at first. Sometimes, there's an adjustment the first couple months, and then the person gets back into, sort of normal life. Everything is working, and there's always the triggers. And it may take years. For some people, it could take many years later on. You were saying, Gary, that you were during the Vietnam era. So you probably can maybe talk to that a little bit about how it takes years for some people. Can you give him the microphone?
Yeah, for me, when I came back, it was quite a while before I realized there were things that bothered me, like loud noises particularly. And they still do that. Once in a while, I'll still hear something that sounds like what I heard. And
yeah.
It makes me pretty creepy.
Oh, yeah. Yeah. So, yeah, that's definitely something to look for. As a matter of fact, the majority of people I see or talk to, there are other therapists who see people who come back from deployment. They probably see people way like a year after, quite often a year after they came back. And sometimes because they've been waiting for the military to do that, the VA, they've been going back, and by the time you get processed, by the time you get to see somebody, sometimes you just get diagnosed, but you don't get the ongoing treatment. And so you have to wait. And so we may see them a year, 2, 3 years later, just because they've been waiting, and finally they say, well, I really got to see somebody. So, okay.
Well, also, the
Go ahead.
unconscious did not forget.
I'm sorry?
The unconscious did
Right.
not forget.
Right.
And I want to ask Jerry, do you have dreams still?
Not anymore. I did. I had a recurring dream for quite a while, but it's kind of gone away.
But the unconscious does not forget.
Right. Right. So we know everything is registered the way it was. Every experience that we have, it just basically is registered the way we experienced at that time. You know, through time, sometimes it gets more complicated because our perception of what happened changes as well. It actually builds up. And that's where cognitive, I think, therapy does really well, is because by the time you see someone, sometimes maybe years later, their idea of what happened and their experience of what they remember is way bigger than what the actual experience is. And that's why it's so important as early as possible to bring them back and basically walk them through the experiences. And we know that the sooner you debrief them, the sooner you go through that process, the better it is for them. And also, let's not forget group therapy or group, when they talk to each other, that's when, especially early on, with the platoon they've been, or with the same people they've been together, when they come back, if we can keep them together and work it out, that would be great. But again, they come back and they go to different places a lot of times. And to me, that's again one of the beauty of video, is that we can get, well, I know the system we use, you can have up to 16 people on the screen, live, talking to each other from 16 different places. So to me, that's one thing I want to advocate, and that is that when everybody goes home, you can bring them back once or twice a week using video, and they can talk to each other. The therapist is only going to be the facilitator, so they need to talk to each other and also help each other know how they're doing, how they're managing. Some people can manage better than others, and and they'll trust each other. They've been together for a long time. So that is probably the best way to help many of the people who come back with post-traumatic stress disorder or any disorder, is to keep that connection for a period of time afterwards. Provide that access for them. And again, that's one way to do this. So again, exposure to combat. You're talking about IEDs, sniper fire, suicide bombs. You never know who's going to be around the corner. I was never in a war, so I can sort of, see what I saw in the movies and what I read, but I can't imagine what it's like actually being there. And again, if I get somebody who comes to me that their experience is so severe, there's no way I'm going to work with them. Yes.
Dr. Aroney, we also have James Craig wanting to share an experience of his.
Oh, great.
It's even smells that may trigger things.
Oh, yes.
I was in a new restaurant and had Vietnamese food, and the smell of, forgive me, but Nhuk Mom set me off. And I recall the odor from a BC cooking smells. This was many years after being in the RVN.
Mm-hmm. Mm-hmm. Well, we know that smells is the most likely to bring back memories, and and again, you wouldn't even know that you're being triggered by smell. You may go to a restaurant, and you're eating, and you don't know why. You came in fine, and you walking away being agitated, being anxious, starting a fight with somebody. So yeah, thank you for sharing this. And as the last thing he says, combat veterans describe exploding vehicles, body parts being thrown about, and being blanketed with sharpened nails as common. We see it in the movies and we think, wow, right? But that's the real thing. So, okay. We'll go through this a little bit faster, really. Again, there's always going to be a process of adjusting, and it's going to take time. and you can't rush people. You can't rush the family. It says, okay, come on, get over it. You know, it's like, okay, we've done 5 sessions. And one of the other difficulties is in situations like that is that if the insurance covers 12 sessions, or the person can't afford $150 or $200, whatever people will charge, right? So you see them for a few sessions, you know, the 12 sessions they're covered, or maybe even you get a few more, but very often it's not enough. Then what do you do? Then we have a dilemma. Learning to share and cooperate is really important. We talked about family conflict. Remember, there is also when somebody goes overseas and the person is being deployed, there's going to be detachment. And when you come back, you need to deal with reattachment. And that's in itself, emotionally, as we all know, is a real challenge. Again, sometimes they want to go back. Okay? I mean, you think like, why would you want to go back? But that's what's familiar. They within a short period of time, that was home for them. That was where they felt safe, they felt loved, they felt accepted, they felt like they belonged. They come back home, and all of a sudden, to some people, it's a very strange place to be in a very short period of time. Okay. Just kind of we'll go through this real quick. And again, I put some of these notes, not so much for me to talk about, as I didn't want you to spend your time taking notes. So by having a copy of all that, you know, you can go through that. Okay. Relationship-based treatment is really important. We talked about how you want to draw the spouse in. You want to draw the family in. You want to even bring in sometimes the extended family to be supportive, you know, if you have the option to do so. Resilience, empowerment, and responsiveness to couple is vital. This is really important too, because some therapists sort of follow their own model, and they just do what they think is they've done all along. So they treat people pretty much with post-traumatic stress disorder the same way, and you have to be really careful because you really have to customize it, because every situation is different, you know. So you do have to think in terms of, you know, what are the needs for this particular family specifically, and it will be different from one family to another. Kind of talked about that. That's another thing, just sort of a reminder for myself, is that sometimes we make the mistakes in focusing on the label, on the post-traumatic stress disorder patient, rather than the patient who has post-traumatic stress disorder. And that's true for you as clinician to keep in mind with any type of client you're going to work in. You can't label the client with the disease or with the illness. And people tend to do that, especially at the beginning, a lot more than later on. But always look at the person as a whole, and just know that they're dealing, or they're struggling, or they have to work through whatever the issues are, so that you don't just focus on the post-traumatic stress disorder with the family. You make the family system an issue. You look at the environment. You know, you're dealing with the kids. You're dealing with everybody involved.
Also, we have another comment from James Craig. There's a tendency, especially among senior NCOs or junior officers, to intentionally detach so that they don't feel guilt about orders that have to send men to situations that may result in their death or serious injury.
Right. Thank you. And please keep bringing comments in, especially those of you who have been in combat or who are online, or anybody here. That does help us kind of understand, you know, from firsthand experience some of this stuff. And as I was talking to Dr. Grimes earlier, in terms of the school creating more and more classes and lectures and seminars and educational tools for the students to learn. And I was saying it's really going to be important to bring in people either to talk to the students or to teach people who actually been in combat, people who actually been there, done that, or those who've been there, have gone to therapy, have worked through their stuff, and they have some, certainly more credibility than somebody who hasn't. Let's see. To beyond, again, you got to go beyond that PTSD model that this is what we're treating. Okay. Basically, there are 3 clusters, symptom clusters, that I kind of put PTSD into. One is re-experiencing. We're talking about, Dr. Allen was talking about having dreams and stuff like that. It's kind of, more like nightmares than dreams, or memories that just keep popping sometimes out of nowhere. You just kind of don't know when it's going to happen. And then you have avoidance, right? So that you have people who are trying to avoid the avoid their feelings, avoid the pain, and anything from substance abuse, which is a huge way to avoid, medicating yourself, to I had a client, which kind of remind me of avoidance. I had a client who just got out of his 3rd deployment, came back, and I noticed he had a lot of tattoos, kind of all over, tall guy. He's about 33. So we started talking, and I noticed that many of their tattoos dealt with military symbols. So I said, well, let's talk about that, because this is part of what you're dealing with. Well, what happens was, about 2 years prior, I think after his second, I don't remember if it was after his first deployment, when he came back, the way he avoided a lot of that, he started having tattoos. He said the pain of having the tattoos relieved him from all those memories for a period of time. So he would do that for a while, and then some of the memories would come back, some of the anxiety would come back. He would go, just keep working on the tattoos. And for 2 years, that's what he would do. His whole body was pretty much tattooed up. So I told him, I said, I'm glad you're here now, because you have no more room to do tattoos. Now you really got to deal with it. He says, yeah, I know, I really got to deal with that. So, but that's another way to avoid, dealing with any of that stuff. And increased arousal, hypersensitivity. Again, you go someplace and you hear this car backfires. It's like, whoa, it's like, it takes you back. So in terms of the symptoms for re-experiencing, how much time do I have?
That's 11:15.
Okay. The re-experiencing are hard on the family members because they don't expect it, right? So all of a sudden, something happened, and the person is re-experiencing a trauma, and he's being agitated and being anxious, and he or she may not even know why at that point. And so how would the family know, right? Sometimes they'll feel ashamed, they'll be embarrassed, they're exhausted. All those feelings are going to flood. They're going to come back in. Anxiety and let's talk about flashback and nightmares, very common for people who come back from combat. Spouses and other family members are likely to feel confused, shocked, afraid, helpless. Can you imagine just those feelings alone, confused, shocked, afraid, and helpless? Can you imagine living with that? That is awful. This is a lot to carry. And that's why they need the support. That's why they need to talk about it. That's they need, a way to resolve it. If the service member does not want to discuss the situation or event, again, the spouse will feel like they're not part of it. They're being left out. Again, obviously, when you have nightmares, a lot of times you end up not sleeping together. You end up disconnecting with the person, losing emotional and physical intimacy. Okay. The implication for treatment, assisting the veteran in educating about the experience. Education is really important element in working with this population, explaining to them, getting them to understand how it works, what are the dynamics that are at work there. You always need to know that when you're dealing with a client, you got to meet him where he is or where she is, and they know more about themselves than you ever going to know. So ask them the question, and they'll tell you. You know, they know more about it. And if you start acting like you know all this stuff because you read the books and all that, you're going to lose them. Did you have a question?
If you want, yeah, we can definitely do it.
Okay.
Eric Nath actually made a comment kind of talking about the difficulties of working through his own war PTSD. It was sorting through the horrible experiences, the guilt, the shame of killing, and the feelings of camaraderie, pride, and purpose all at the same time.
Right.
And it would have been easier if it wasn't mixed with some of the most important times of his life.
Oh, okay. Thank you. Yeah.
That's pretty powerful.
Yeah. Yeah. Part of the education is educating the spouses and family members, educating actually the veteran himself or herself. What do you want? What do you need? A lot of times they can't ask it for themselves. They think they're not supposed to ask for it. They think that they should. Everybody should know. But we don't know. So it's okay when you do couple counseling, is to say, well, what is it? How would you want to deal with such and such? What is it that you need at this moment? What would work for you? A lot of times say, well, she knows or he knows, and it doesn't work. Stop assuming. That's true for any kind of clientele. A lot of times we tend to assume that the other person knows. So education goes a long way. You want to encourage the veteran to show the spouse how to assist him while re-experiencing the trauma. So that's another thing, is you want the person who's going through re-experiencing, going through the trauma again, especially when after the fact, when they're talking about it, you want them to express to their spouse how they want to be. Do you want to be left alone? Do you need some space? Do you need a hug? I mean, what is it that you need at that moment? Some people say, I just want to be left alone. Just give me some space. Half an hour later, I'm okay. Some say, I'm okay and I don't need to talk about it. Let's move on. Some say, I'm okay and then I can start talking about it. Some will say, I just need you to hold me. I just need that physical, tension to know that everything is okay. So it is important to have the person who's going through those experiences to really, because they'll know what they need. Problem solving, we know we need to educate people on that. Importance of safety, because a lot of times they'll come home and there's no sense of safety or security. Team approach is really important. I'm big on team approach. So you can involve the physician, you can involve social workers, you can involve other community leaders, religious leaders. A lot of times they find that spiritual leaders will help some people who tend to be more religious. So you want to bring in every community resource that you might have, okay. On the avoidance symptoms, avoidance promotes isolation. Sometimes a person would avoid the whole family. Sometimes it's physical, sometimes it's just mental. They just shut down. And the more they isolate themselves, the more distance is going to be between them and the family. Emotional intimacy is a prime predictor of marital satisfaction and stability. It is impaired in veterans with post-traumatic stress disorder. And again, that's a lot of it due to numbing. You can imagine that you're just going to numb yourself emotionally for a while. Treatment implications, some more. Difficulty expressing care and concern. There's, again, part of the stress when it comes to sexual disinterest. It's you shut down, and because getting sexually involved again is going to bring up a lot of feelings, a lot of intimacy, a lot of vulnerability. And so it's that fear that kind of, if I'm going to be more vulnerable and then we're going to be upset about something, it's going to set me back. Yes.
You touched a little bit on kind of a physical interaction. Anthony York has a question. Where's the line when it comes to that physical support?
Well, that's where you have to find out from the person himself or herself, right? That's why you need, everyone has different level of comfort when it comes to physical support. And in some cases, you have to go back to desensitizing a person because they've removed themselves for quite a while. You need to start slowly re-engage them. It may be with the spouse where you just hold hands for a while. It may be where you just put your arm around this person's shoulder. It may take months. But again, you the therapist can decide when it's time. Okay, now you've been holding hands long enough, so it's time to kiss. They need to get desensitized and re-engage. Good question, thank you. Next one. Again, infidelity is sometimes a way to get. It's kind of safer for a lot of them to have affairs, to reconnect for the moment with someone else because they don't have to tell them the story. They don't have to, go into anything. And that's a safer place for them to go. So we need to kind of know that, infidelity can take different meaning. Does it mean that the person is, under normal circumstances, maybe there's problems in the marriage itself. Under those circumstances, it may be just an escape. Different ways of re-engaging the family and the spouse. We talked a little bit before about loss of friends in terms of guilt. And it's another area of difficulties if they lose close friends. There's that fear of re-engaging back in civilian life with friends and family because the thought is, I may lose them as well. And then remember, a lot of it isn't just logical, it's just a lot of emotional consideration. Okay, again, we kind of talk about that. Very important. It isn't enough to do all your work inside your office. Okay, you see the client once a week, maybe, or twice a week, maybe, sometimes longer periods of time. And you're talking about it and explaining and educating. The real work happens outside your office. The real work is to get them involved back as soon as possible, back with activities. Sports, physical activities are one of the best way to get back into dealing with stress, dealing with post-traumatic stress, doing things that whether it's hiking or playing tennis or playing baseball, whatever it may be, it gives them something that they can feel that they are being productive, something that's enjoyable to them. Getting back as early as possible to being involved in the community, maybe through volunteerism. Maybe somebody used to tutor and they can volunteer, at-risk kids or at the church or wherever they in the community, there's places. But get them back into activities, very, very important. It's also important for the couples and the families to do things together outside the house. Communication skills, that kind of goes without really saying. We know that we need to help them speak the same language. Okay. When it comes to arousal, when we're talking about that kind of hypersensitivity, sleeping is always an issue for people like that. They don't sleep well, so very, very lightly. There's a lot of fatigue involved, and then if they go for periods of time without sleeping well, they get tired. And when you're tired, all of us know when we're tired, we get a little grouchy, we get a little irritable, right? Even if we're tired just after one day of not sleeping. So the startle response, as Gary was mentioning before, you hear noises, sounds that you're not sure what those sounds, where they're coming from, especially in the dark, and that gets you triggered again. And again, what the consequences for that is that the whole family is walking on eggshells because they just don't know when you're going to explode. When it's going to be that next time that you didn't expect it. So there's additional tension. So you can just imagine how tension just feeds from one to another to another. So you may go along, everything appears to be okay, but everybody inside kind of feels stressed out and everybody's walking on eggshells and nobody knows what's going to happen. And sometimes it's sort of a self-fulfilling prophecy. I mean, you're creating so much pressure that you have to have something to release that pressure. So there's a good chance that if you expect something to happen, it probably will happen. You know, so again, it's part of, if we educate our clients that is probably what's going to happen, it helps a lot. Being critical, it's another thing that we have to kind of work with. Sometimes because of the disengagement between people, the way people try to engage is by being critical. So being critical with your spouse or with your kids is sometimes need to be looked at not as something bad, but rather something that it's an attempt to engage with that person. But when it comes out critical, of course, everybody shuts down. Okay. Not being non-judgmental, as therapists, we know that's a really critical aspect of our work, and especially with this population, is that we need to accept them for where they are and what's going on with them. You know, for you to start making judgment of what works, especially when you haven't been there or haven't been in their shoes, they'll sense it right away. The idea is that you have to create a relationship with your client. Let them talk. A lot of times I find that very often with this population, more than anything, they just need to talk. They've got a lot to say. Now, I'm fairly goal-oriented kind of therapist. I'm fairly opinionated in my work, and I'm pretty much direct with a lot of people. That's just the way I've always worked. But with this population, I have to sit back. I need to be more patient. I need to remind myself, just, okay, you know, I already formulated exactly what they need. I already know exactly what they're supposed to be doing to do it right, but I can't do that with this population. You can do it with other populations that a little bit have the support. This population, you really have to remember that they are in pain a lot of the time, and you need to sit back and let them talk, let them tell the story. You can ask them for more and more details as you go along. Get them to tell you more and more about what was really going on. And they'll kind of let you know how far they'll let you, what kind of questions they're going to answer. You know. Okay, so being non-judgmental. Assisting couples in coping with expression of anger and general irritability. I tend to think of anger not as feelings, but as behavior. I kind of call anger secondary feelings, even though we all say, I feel so angry and feel so irritable. To me, those are not really feelings. Because when you're angry, there's some feeling underneath that. Fear, hurt, jealousy, whatever it is. So you need to be really sensitive, and so most people think of anger as, I feel angry, she made me angry, or he did this and that, right? So what you only want to do is educate and talk to them about what caused the anger. Let's kind of deal with what is happening that brought that anger about. And then educate them that there are different ways of expressing anger, and there's certainly good ways to express anger. I mean, to punch somebody out when you're angry is not necessarily a good thing. There are really not good consequences to that. Okay, but telling someone you're really angry, or being able to write them a letter that they're angry about what happened, and focusing not on the person but on the situation is really helpful. So if somebody is irritable, so I say, well, you know, he's always irritable. He's always, yeah. Let's talk about what gets triggered. What are the feelings that they're experiencing? So again, triggers are important. Coping strategies, a lot of it is educational stuff that we should have some skills and tools in our tool bag to kind of offer them. One thing that I like to do a lot is that I'll give a lot of like 1 or 2 page of information, tips, you know, things to think about that they can take home with them. Because a lot of times they'll walk away and forget everything, or they just don't really think. So I like to give a lot of resources, short, to the point of what we talked about. Sometimes we'll talk about some things that came up, and by the following week, I'll email them. I'll say, okay, I just found out this, here's some great, a lot of stuff is not my own stuff. I just Google stuff. There's so much resource out there between books and journals and research that you'll find that's about anything you want. So what I do is I'll get on the internet and I'll Google the information that I want, because I don't have time to read a whole book between then and next week, because there'll be several people that I have to do it with. So what I do is I kind of do summaries, and I do a lot of bullet points. Here's what we talked about, and how about if you consider, here's some ways to deal with that. Here's some thought that you might want to, some stuff you want to look into. And that seems to help them because it becomes black and white, it becomes more real. And a lot of them will use it, come back the next week, says, wow, you know, this was a really good idea. I never really thought of it. Okay. And obviously displacing your energy and your anger, you know, like kicking the dog when you come home. It's, again, being able to recognize, you know, for the person who's going through it himself, recognize the triggers. Recognize, a lot of times what I found after talking to a client for a while is you get them to recognize what's going on in their body before they act it out. So what I do is I like to ask, kind of get people, where do you feel it first? Do you feel it in your forehead? Do you feel it in the back of your neck? Do you feel, you know, do you feel it in your stomach? Is it a tight chest? Is it in your left toe? I don't know. But it's usually some physical sensation that people seem to have to recognize before things build up. And once I can get them to recognize that, then it's easier for them to sort of short cycle that process and relax and not let it get to the point where it goes out of control. Let's see. Okay. And obviously it's an issue of having respect. Respect is really big for military people because when they're in the military, respect is probably one of the number one things that they're trained for, you know? So a lot of times they come home and spouses, they feel like the spouses are not treating them with respect because they have a different meaning for respect all of a sudden, you know? And so a lot of times I kind of like couples especially, to kind of communicate about what is the meaning of respect, what defines respect, what behavior, what tone of voice, what do you expect? Okay. Let's see, time process. Okay, let's kind of move along. And obviously rehearsal and role play is a really good technique to help people through. I do a lot of that with couples where they switch roles. Or I'll play one of the role. And so that when you have this role playing, all of a sudden they have the point of reference changes. And when you see something from some other point of reference, everything changes. It's like, it would be different if I sit here, stand here, or if I stand in the corner over there, everything looks different. Right? So, although nothing changed here. Okay, so briefly, we talked a little bit about TRICARE. I put this slide in for you, just to give you information about the TRICARE, what it is, and their website. So if you want to get more information from specifically regarding their insurance, their coverages, not so much necessarily for you as a provider or somebody working, but all this information is for them, available for them on there. There's all kind of articles, there are all kind of support system for them available almost in every community, every region, every country, every state, and every city. So they have that. TRICARE and TriWest is, I think, part of the same company. They oversee everything in the United States for the military. Okay, so let's talk briefly about online. What is kind of online? Because I want to show you a little video so they kind of have a sense. I mean, some of you recognize familiar with Skype. You know, it's free. You can connect people, but Skype is not reliable, and to my knowledge, also it's not HIPAA approved. It's not. You have to also deal with the security issues and confidentialities. But we do have other systems that are encrypted, and nobody can break into those things, so that they're just as secure as somebody coming to your office. Because that's your main concern, is when you're dealing with somebody in a distant location, is that you have to make sure that nobody can breach, that connection. TRICARE Online has a web-based video counseling. They offer private personal behavior health support. Let's see, we went to this. Okay, so now you've got basically what it is you got two computers, whether it's laptops or PC, whether it's Mac or whatever. Nowadays, any place you have a connection with the internet between two computers and a webcam, you can actually connect with a person just by clicking. So you can set up an appointment, schedule or pay for it, with a MasterCard, and have a session, a scheduled session. This is a group therapy, and just a group of veterans gather in one room for a therapy session. So I don't know if you can see. There is a. Guess what? I know how to use this. There's a monitor over here. It's kind of a dark picture, but there's a monitor here, and the therapist is really actually in the monitor. So he's farther away. So you've got people all gather in one room. They're all in the same facility. The therapist facilitates that, and also you have more veterans joining in on the screen. So you can actually bring people together. And what happens is that at first it kind of seems strange because you're talking to someone but 5-10 minutes later we find that you forget that you're really talking to someone on the screen. That you actually, especially when you do one-on-one, what you really do is you find like you're almost in the same room. And so it's an adjustment for us to make, but it's fairly easy adjustment to make. This is just a little resource information. You can go to websites, and then again, it's all you have that in your in the printout. So this is pretty much what I've got. Any questions? Anything you'd like to share? Anybody from the audience out there?
Okay, we have a question from Cheryl Ballon. My dad is a Navy veteran, but not a combat veteran. Are there any suggestions for family members or specific triggers to be aware of in relation to the Navy? Is there a PTSD in this population as well?
Well, there's definitely PTSD in that population because a big part of that population is either experience, whether in the Navy, a lot of times people will be in submarines, for example. They don't necessarily have to be in combat, but when you spend time in a small place underwater and in submarines, you're going to create, a lot of them will create post-traumatic stress disorders. Again, not being a Navy person and not being really a military person, there are resources for every single sector of the military. And all you have to do is just contact that particular resource. The DoD, the Department of Defense, and the VA have a great deal of. The main thing is that there are too many people to service, and not enough money to service them. But the resources are there when you're looking for it. Okay.
Anthony has a question. He wants to know, is it possible to work under the license of an individual to treat military personnel? Do you know?
Well, as an intern,
Don't know.
can you tell me? Are you talking about as an intern or trainee? Because as an intern, you can, as long as you're being supervised by that person. And again, the only difference is that you will not get paid. You can't bill an insurance company for if you're an intern or trainee. But as long as you're working on the supervision, yeah, definitely.
James actually helped to answer that question as well. He wrote that he would presume that there's a licensure issue with respect to conducting online therapy with multiple persons who may be in different states. Is that an issue?
No, there's no licensing issue there. In terms of different locations, the only licensing issue is that you are licensed and you're competent and you have liability insurance. As far as being able to use video, that is an acceptable mode by the department, primarily because I think Stryker realized that they need civilian therapists. That's really the main motivation, for that. So, but there are a lot of new rules and regulations going to come about as the technology changes and as we are using internet. We're breaking a lot of barriers. Before, it didn't make sense to have to practice in every single state. And a lot of it is territorial as far as why can we practice in the state that we license? It's political. It's not because, I can't work with somebody in Arizona. Somehow they have different mentality, They might, I don't know. But the reality is that it used to, I mean, I think the main reason politically was that you pay your fee to the state, and the state issues you the license, and then every 2 years you pay another fee and another fee, so that it's a, you know, so that's the reason for that. Yeah, Dr. Allen.
Earlier, you had talked about, we can't use a one shoe fits all,
Mm-hmm.
but the, it's already been set up for us, 12 sessions fits all, and that's just not gonna be true.
Well, but what you do within the 12 sessions can be the same. So
Can you renew the 12 sessions?
in some cases you can renew and they'll let you go for another 12. Some I don't know about TRICARE so much. That there are insurance companies that every time they're going to request every so many sessions for you to send them a letter why you need another 10 sessions or whatever. So
Excellent.
yeah, yeah. Also remember, we normally as therapists, you know, the traditional mode is to see clients once a week. And that is really more to serve the therapist than the client. I mean, that makes it convenient for us therapists. We know we can schedule people once a week, and that makes it easy for us. But it doesn't necessarily mean that it applies well for the person. So we in part of customizing, it may be that you want to see a person 4 times that week. So just because you get 12 sessions doesn't mean that you need to see that client once a week. I think the rule is you can't see the client the same day for them to cover it. So you can see them actually every day and 12 days in a row too. And I've done that too. I've done sessions where it isn't just once a week. It's like, well, let's kind of work all week long on that. And then, because we get a head start that way, you know. But I customize my session to all my clients.
One more question before you,
Yes.
our program ends. You're seeing a patient, they're suicidal. Does the therapist have any means to help get that person into a hospital?
In terms of remote areas.
Yeah.
Yeah, that's a really good question that we are struggling. What we do now is that if somebody in a remote area, we make sure after the first session that we have contact in that person's neighborhood or where they live, the city, what hospital is nearest to them, and in case of suicide issues, who they need to contact, because they will be obviously in a physical location. But that's also true for people that you see in your office. They're not likely going to be in your office when they talk about suicide. So they're going to call you, you're going to call the PET team, or you're going to call somebody. So we make sure that we have this information available when people leave. But that's a really good point.
And adjacent or a tangent to that is that 30-day statistic that you gave us, that many of these people that committed suicide had been seen within a month just prior.
Right.
So either the therapist is missing it, or that needs to be investigated
Yeah.
as to what in the world is happening where we have therapy so close to the actual event.
Right. I have not seen any actual research or any kind of information relating to that, so I'm not sure what is really going on. Why is it so traumatic that it doesn't matter what the therapist is going to do, that person's going to kill himself anyway? You know, so we don't really know.
Yeah, if that were to happen, you have your therapist in therapy.
Yeah.
From the guilt of what did I do?
Yeah, of course.
How did I miss it?
That's it. Yeah, yeah. The other thing about working with remote therapy is sometimes the clients you can take. If you know the client ahead of time is suicidal, you probably don't really want to take that client. You want to make referrals. Same thing if somebody is psychotic. There's certain kind of cases that you will not take in terms of working with remote areas. That's you. Okay. Anything else? Yeah.
Yes, to clarify the question from before, Anthony, he wants to know if you can do it not as an intern, if you can work under someone's license with the military, not necessarily as an intern supervised, but can you actually do therapy under someone's license?
I don't believe so, because first of all, somebody with a license isn't going to accept somebody who's not an intern, because they have to qualify through a certain amount of educational units and supervision at school. So you can't do that. Now, the military is a little bit different. Military have their own rules, so I'm not familiar with actual military rule if they can use people who maybe have certain certification or certificates to work rather than being interns. So I'm not sure about that. Now, I do know that priests and ministers, people like that, are licensed to do therapy as well. They're not necessarily therapists per se, but they also have, I think, the legal right to do therapy. And they do, they administer therapy a lot.
As a final comment.
Okay.
Are there any other questions? We have a final comment from
Sure.
James, and he's one of our vets that's been online. He suggests that therapists read Colonel Grossman's Bulletproof Mind, which is a book used to train warriors to develop a mindset that protects against the mental stress of taking life.
Right.
Yeah.
Great.
So have
Thank you.
heard-
Thank you very much. Yeah. No, I haven't read it. I've heard of the book, but I'm going to read it next. So.
Perfect. Do we have any other questions?
Well, I want to thank you all. This has been great. I hope it wasn't too boring, because I know a lot of
Thank you.
facts.